इसको हटा दो स्क्रीन को.
Right, sir.
Hello everybody, greetings from Indian Medical Association and Confederation of Medical Association of Asia and Oceania. I'm Dr. K.K. Agarwal. On behalf of IMA, I welcome you all on 35th IMA weekly resource seminar on COVID-19. Hand it over to Dr. Ashokan, the Secretary General of IMA. With a request, tomorrow is a working committee and kindly propose to continue this for another 1 year. Till I'm there on the CMAAO post. Will request you to get it, float the idea. I can't ask. So if the IMA wants, I'd like to continue this weekly seminar with a new team. Dr. Ashokan.
Thank you, Dr. KK sir. It's a great service to humanity that Dr. KK Agarwal has taken upon himself as a resource person of IMA during this COVID epidemic. 35 sterling webinars, which are available free of cost to anyone who would want to look at the IMA website and learn. I think nothing more could be said about this service. As a matter of fact, yesterday we have honored him with the highest award that Indian Medical Association can prefer to any doctor. We are grateful for your service, sir. I will certainly put it up to the working committee. See that your service is continually available to all the members of the profession. And welcome to Dr. Rajesh Chawla,
Thank you, sir.
Pulmonologist, critical care and sleep specialist from Apollo Hospital, Delhi. Welcome to IMA family. The one that we prefer is that we do live stream this, but we allow our general practitioners and members across the country to access this golden mine of knowledge in IMA website as and when in their leisure. So that is how we try to impart this knowledge of these webinars. Welcome to you, and on behalf of Indian Medical Association headquarters, I am grateful for your presence and your imparting of knowledge. Thank you, sir.
Thank you.
Just want to add that Rajesh Chawla is also the past state president of Delhi Medical Association.
Oh, that is excellent. That is, I didn't know that.
After offering his services in Delhi Medical Association in 1998, he's one of the senior most past president of Delhi Medical Association.
Excellent.
But now he is more in academics with that. And so welcome everybody here. The topic today is lung fibrosis, an important subject because everybody today wants to know, because many studies says that up to 50 to 70% people may have diffusion abnormalities during COVID-19. That means their diffusion lung to carbon monoxide, which is DLCO, may be impaired. 30 to 40% may have some degree of fibrosis. When we say fibrosis, remember the word honeycombing. If there is a honeycombing in CT scan, you know you are dealing with some degree of fibrosis. You're talking about interlobar septing, then you can have bronchiectasis, bronchiolitis. If these are the words you see, you know that some degree of fibrosis there. Question today is this fibrosis progressive like IPF? Is the fibrosis reversible? Or it is like a TB fibrosis which develops once develops, but TB fibrosis is never like an interstitial lung fibrosis. Are we heading towards pulmonary hypertension epidemic in the future because of residual fibrosis leading to pulmonary hypertension? Are we going to have lots of patients with secondary infections or home oxygen dependent? Let's listen from horse's mouth, Dr. Rajesh Chawla.
Thank you very much, Dr. KK and Dr. Ashokan, for nice introduction. See, I'm going to talk very important and a condition where I'm really worried because next decade is going to see a lot of post-COVID pulmonary fibrosis. Unless we have some medicine for it to curtail the progress of this, otherwise a lot of people are going to be crippled and dependent on oxygen in the coming. So let me discuss few cases before I discuss the pathophysiology and the options available. Case 1 is a 48-year-old patient with no prior comorbidities presented to the emergency department with dry cough, fever, and throat pain for 5 days. No significant travel or contact history, saturation 92%. Laboratory investigation showed lymphopenia, elevated LDH, raised C-reactive protein, and elevated D-dimer level. Chest radiograph revealed peripheral multiple inhomogeneous opacities in bilateral lung field. RT-PCR was positive. He was managed with oxygen, low molecular weight, dexamethasone, and antipyretic. And this was the CT scan. As you can see, there is an architectural distortion. There is a thickening of the interlobar, septal thickening, which is suggestive of, and there is a traction bronchiectasis, as you can see on the left side, long bronchi which are being pulled. That is called the traction bronchiectasis. And both actually you see, and all these three things are suggestive of pulmonary fibrosis. So he was symptomatically improved, but continued to have hypoxemia even after 3 weeks of treatment. He was discharged on home oxygen therapy and was planned to enroll in antifibrotic therapy trial. Another patient, 65-year-old, admitted to the intensive care unit with severe confirmed COVID-19 pneumonia, history of diabetes, fever, cough, and shortness of breath. And as you can see on the coronal section of the CT scan, there are ground glassing and consolidation on the left side. You can see an area of consolidation, which is subpleural. The patient was put on invasive ventilation, was given a lung protective ventilation. He required prone positioning and the inotropes to maintain the blood pressure. He was given empirical antimicrobial therapy along with hydrocortisone. He was also given tocilizumab. After initial improvement, the patient condition worsened. And you see the CT on day 20. Already, it is so early, a patient who was normal gets this disease, and day 20, as you can see, not only there is a ground glassing, fibrosis strands you can see on both sides, it has started setting in. Multiple organ persisted. He had a ventilator-associated pneumonia with a rare bacteria, Citrobacter kozeri and Acromobacter. And then, as you can see, by day 40, he had a cavity, and there were multiple the areas of bronchiectasis and fibrosis on both sides by day 40. So this is the speed with which this disease can develop into fibrosis. Although cavity is usually seen with a secondary infection, difficult to say whether the IL-6 decrease because of the immunosuppression predisposed to some infection, because these bacteria do not cause cavity. There was a cavity formation along with fibrosis. Another 38-year-old presented with 6-day history of gradual worsening, cough, anesthesia, and secondary anosmia. No prior personal medical history. Mother had diabetes. His son was followed for hemophilia A. Spouse had exhibited similar symptom a week earlier. He had symptoms of crackles, tachypnea, and tachycardia, oxygen saturation of 66%. His blood pressure was normal. And you can see the CT scan again, extensive ground glassing on both sides, predominantly in the lower lobe, with areas of consolidation. Patient was put on oxygen and high flow nasal cannula and was given 50 liters per minute with a FiO2 of 1, along with antibiotics, and prone therapy was also done in this patient. Over the next few days, the proning was done regularly. Patient did not exhibit any clinical sign of respiratory distress. This is another thing, because these patients have happy hypoxemia. In spite of being so hypoxemic, they may still appear normal. and can falsely give a false sense of security to the patient that I am well, actually he is unwell. So considering, because he was maintaining mechanical ventilation was not initiated, then the antibiotic, he was continued on the HFNAC. The antibiotics were discontinued because there was no evidence of infection. On day 10, still required high flow nasal cannula. And then this was the CT scan repeated. As you can see, the fibrosis, interlobular septal thickening, and area of ground glassing and fibrosis is already set in this patient by day 10. Treatment, he was treated with a high dose intravenous steroids followed by oral steroid 1 milligram per kg and was given 9-antidanib. He improved and was transferred to the ward on day 18 on oxygen therapy of 6 liters. So this was just to give an idea of the different kind of patients. The last patient, because over the 8 months I've been treating these patients, what I have realized is that giving a high FiO2 on HFNAC or non-invasive ventilation has led to definitely increase in the fibrosis. Everybody feels happy that they have not ventilated these patients. But because of using high FiO2, the fibrosis is much more, and these people, these are the people you are not able to take off the high flow oxygen in these patients, and they keep on suffering for a long, long time. So lately we have changed our strategy of ventilating these patients like we ventilate any ARDS patients, and we are not only finding we are able to extubate them early, we are also avoiding a lot of fibrosis in these patients because we don't use high FiO2 in these patients. So, you know, the basic illness in this COVID, it causes ARDS, although the variety of ARDS is set different. If you look at the ARDS, the duration of disease, ARDS also determines the fibrosis. If a duration of ARDS is less than 1 week, fibrosis is 4%. If it is week 1 to 3 weeks, it is 24%. And if the ARDS remains more than 3 weeks, the 61% of the patients would develop fibrosis. So it suggests that any potential antifibrotic intervention should be considered within first week of ARDS. You know, I'm talking about ARDS in any patient. The pathological feature of ARDS is diffuse alveolar damage. Initially, there is an exudative phase, and then there is an organizing phase or the fibrotic phase. A substantial portion of patients who develop ARDS will have a long-term impairment of lung function and CT evidence of pulmonary fibrosis. And anterior reticulation is the dominant abnormality in these patients. Early analysis for patient with COVID-19 on discharge from hospital suggests that high rate of fibrotic lung function abnormalities. As Dr. Agarwal was also saying, 47% had impaired gas transfer, and 25% had reduced total lung capacity. And this was much worse in patients with severe disease. It has also been found that the 40% of patients with COVID-19 develop ARDS, and 20% of ARD cases are severe, and more than 1/3 of recovered patients develop the fibrotic abnormalities. Cytokine storm, which caused by abnormal immune mechanism, may also initiate and promote the pulmonary fibrosis. And there are various mechanisms, epithelial and endothelial injury, as well as the cytokines such as IL-6 and TNF-alpha are also involved in the process of fibrosis. In fatal cases of COVID-19, the pulmonary fibrosis autopsy has been done in China. They are generally present at autopsy with anecdotal reports of severe fibrotic organizing pneumonia. Diffuse alveolar damage, which is the defining feature, as I said earlier, has been characteristic histological feature in fatal COVID-19 cases. When certain individuals recover from such an insult, Others develop progressive pulmonary fibrosis due to accumulation of fibroblasts and myofibroblasts and excessive deposition of collagen. This is really not known, that why some people progress to have accumulation of fibroblast and myofibroblast and deposition of collagen, and the other recover. COVID-induced ARDS, there are a lot of researchers have said it is different. They have high and low elastance time from the classical ARDS. CT findings also, if you can see, they are not classically of ARDS, as you have seen earlier, the ground glassing and then lead to consolidation and then fibrosis. You know, the other very important finding in the etiopathogenesis of hypoxemia is the coagulopathy. Is another pathological feature of this disease, and mechanism of pulmonary fibrosis is different from that of idiopathic pulmonary fibrosis and other fibrotic lung disease. Now, what are the risk factors? You know, there are 5-6 risk factors which they have seen predominantly result in a fibrosis. One is the age. Lung fibrosis is reported more often in individuals with advanced age. And as you've seen, the disease severity is also more severe in advanced age. The exact reason for this is, however, is unknown, but it was seen with SARS, it was seen with MERS, Middle East syndrome, and the SARS, the earlier they had seen the similar kind of thing. The age led to the more lung fibrosis. The illness severity. The factor associated with increased disease severity, we have seen there are n number of papers have shown comorbidities like hypertension, diabetes, coronary artery disease, lymphopenia, and elevated LDH. You know, LDH somehow people have not correlated with increased severity, but this is very important marker because serum LDH disease severity following acute lung injuries. It's an indicator of pulmonary tissue destruction. You know, whenever there is a pulmonary tissue destruction, the LDH will rise and correlates with the risk of mortality. The third factor which determines the fibrosis is length of ICU stay and mechanical ventilation. The ICU care is required about 5 to 12% of COVID-19 patients, while the criteria for admission, they differ from one hospital to another or one country to another country. While disease severity is closely related to the length of ICU stay, mechanical ventilation poses an additional risk factor. You know, everyone thinks patient is put on a mechanical ventilator. It is not same. If you do not do properly, if you do not do lung protective ventilation, if you do not do low tidal volume to these patients, the ventilator itself causes ventilator-induced lung injury, and it will exacerbate the injury to the lung, and fibrosis will be more. So it is very important that when ventilation is done, it should be done a lung protective ventilation, and it should not be taken very casually that now a patient is on a ventilator and everything is okay. One has to be very, very careful in ventilator to avoid ventilator-associated lung injury. In a study of 27 patients who are mechanical ventilation for ARDS, the 110 to 260 days after extubation, 23% had pulmonary fibrosis. A significant relationship to the duration of pressure control and inverse ratio ventilation. The fourth risk factor is smoking. This is another thing which has been found, that the smokers have a more severe disease and more severe fibrosis. 2.4 times more likely to need ICU admissions and mechanical ventilation or die compared to the non-smokers. And this is one of the modifiable factor. And even they have seen the current smokers have a higher risk. Chronic alcoholism is also one of the risks because it causes glutathione depletion, chronic oxidative stress, increasing the risk of acute lung injury and pulmonary fibrosis. So these are the few of the risk factor: age, severity of disease, length of stay, mechanical ventilation, smoking and alcoholism. Now, as we know, the disease has been divided into mild, moderate, and severe. Mild do not get that much of a fibrosis. It is the moderate to severe disease. These are the patients which will get some degree. The severe the disease, more chances of getting a pulmonary fibrosis. This one of the studies, it has been there that every person who gets a moderate disease does not develop fibrosis. In one of the studies, they did a CT scan on the last day before discharge, 2 weeks and 4 weeks after discharge. Compared with last CT scan before discharge, the abnormalities like GGOs, consolidation, interlobular septal thickening, subpleural lines, and irregular lines were gradually absorbed in the first and second follow-up after discharge. The lung lesion of 64.7% discharge patients were fully absorbed after 4 weeks follow-up. So patient with a mild to moderate disease, in 4 weeks time, most of the abnormalities were absorbed in about 65% of the patients. So it indicated the damage to the lung tissue by COVID-19 could be reversible for the common COVID-19 patients. As far as the pulmonary functions are concerned, although they are not recommended before, in many of the country, the post-COVID clinic, they are examining patients after 3 months. But in certain hospitals, they do not allow the lung functions 1 month after the person is negative. So it should not be done also. But even what I'm finding that many of these patients who complain of little breathless, there is chest examination is normal. You do the simple spirometry, it is normal. When you do a DLCO, there is a decrease in the diffusion capacity. And that shows that there has been some early fibrosis in many of these individuals. And lung volume are also only reduced if it's a moderate or severe disease. They are not seen in the mild disease. Now, how to treat this post-COVID pulmonary fibrosis? No fully proven options are available for the treatment of post-inflammatory COVID-19 pulmonary fibrosis. Various treatment strategies are under evaluations. This is just to explain how there is a thinking going on about the treatment. The SARS coronavirus attaches to the ACE2 receptors in the alveolar lumen or the epithelial cells, and RGD integrins, as you can see on the cell, they enter through this RGD integrins into the cells, the alveolar epithelial cells, and then by the JNK pathway or the mTOR pathway, the viral replication occurs and it stimulates the inflammasome and it leads to the release of IL-1 and IL-6, which is responsible for the injury to the lung. So various treatments which are being planned are at the various level in this pathway. Although the role of IL-1s in the pathogenesis IFPF is well described, but IL-1 could possibly prevent the development of post-19 fibrosis if you inhibit it. Anakinra is a drug which is anti-IL-1. IL-6 is generally considered to be a pro-fibrotic molecule. So, but an experimental study of a bleomycin model of pulmonary fibrosis where they gave bleomycin in rats and they created pulmonary fibrosis, they found the IL-6 was able to inhibit the pulmonary fibrosis, but later stages of the injury, the fibrotic phase might ameliorate the anti-IL-6. What I'm trying to say is the IL-6 may increase the fibrosis if you give anti-IL-6, if you give in the early phases of lung injury, and it will promote fibrosis. But if you give late, it may decrease fibrosis. So this is just an experimental study. So what are the proposed treatment? One is it could be antiviral, anti-inflammatory, and anti-fibrotic drugs, which could lead to the probability of development of lung fibrosis. So there are a lot of drugs being tried. One of the two important drugs, which all of you are very well aware, 9-NT-Danem every prescription now has an antidanib or pirfenidone. It does not have an impact on the viral infection or disease. The pirfenidone inhibits the acute lung injury, and antidanib does not. It inhibits IL-6, both of them. They inhibit IL-1, both of them. And there are other molecules which are being tried to work on the various points in the pathway which I just enumerated. Now, steroids. Everybody is putting these patients on steroid. Some patients say we are better, some say nobody knows whether it is causing some benefit. Of course, in the acute phase, as per the recovery trial, it did prevent the death. It has a role, but whether it has a role in the long-term use for a low-dose steroids, because it is said that if you give a low-dose steroid, may prevent the remodeling of the lungs in survivors and prevent fibrosis. But many of the patients are being prescribed steroids now when they develop fibrosis. So, but what is the exact dose, how much to give, whether for how long to give, it is still not being sorted out. The rationale for using the antifibrotic like antidanib or the pirfenidone, because there is a fibrosis associated with organizing pneumonia, and there could be to severe acute lung injury, and it leads to the fibrotic phase. So you cannot differentiate. So it could have a role in the management through range of different mechanisms, which I have already enumerated. Pirfenidone is an antifibrotic, antioxidative, and anti-inflammatory effect, and antidanib is again antifibrotic drug. They are available in commercially oral form, cannot be used in patients who are intubated and mechanical ventilated, clearly restricting their use in individuals with severe COVID-19 on the intensive care unit. Pirfenidone should be avoided if patients have an estimated GFR of less than 30. Both pirfenidone and antidanib can be associated with hepatotoxicity, and liver dysfunction is common in patients with SARS coronavirus, so one has to be very careful. The other thing in antidanib, when you give along with anticoagulants which are being prescribed, there is an increased risk of bleeding when they are concomitantly administered with full dose anticoagulation. And there is a lot of controversy at what time they should be prescribed, and there is no advantage of giving them too early in the acute phase. There is clearly much work to be done before this drug could be considered safe, let alone beneficial in the context of COVID-19. You know why they have come into this? These are the drugs which have proven their efficacy for idiopathic pulmonary fibrosis. But there are now some papers where they have found its utility in chronic fibrotic condition. So that's how they have contemplated that they may be useful in these conditions. These drugs do not address the immune dysregulation of SARS coronavirus infection, nor can they be expected to attenuate the prothrombotic aspect of this complex pathogenic process. So the use of antibiotic can only be from the extrapolation from the chronic lung diseases. See, given the scale of COVID-19 pandemic and the number of people requiring invasive ventilation worldwide, you know, it may be very few percentage, but if you see the worldwide, the COVID-19 post-COVID fibrosis is likely to be a substantial problem of the next decade. I'm not talking of 5-6 months. It's going to be a problem in the next decade. We'll have a large number of patients who have fibrosis, oxygen dependent, and breathless, dyspneic, which have to be managed. So to conclude, COVID-19 leads to a wide spectrum of respiratory diseases with an extremely high incidence of acute respiratory distress syndrome. The risk factor for severe COVID-19, as I enumerated, age, disease severity and comorbidities, length of ICU stay, mechanical ventilation, smoking, alcoholism. Their smoking and age, they are shared with IPF, suggesting that this group of patients will be an increased risk of severe COVID-19. The burden of fibrotic lung disease following SARS coronavirus likely to be high. So given the scale of pandemic, the global burden of fibrotic lung disease will probably increase considerably. There is a therapeutic rationale for the use of licensed antifibrotic therapy and acute exacerbation of IPF, including those triggered by viral infections. Available antifibrotic therapies have broad antifibrotic activity regardless of the etiology. They might have a role in attenuating pro-fibrotic pathway in SARS coronavirus infection. Novel antifibrotic strategies have a range of antiviral and epithelial protective effect in models of acute and viral-induced lung injury. Close follow-up of patient after COVID-19 is essential. There is urgent need for therapies that mitigate severe COVID-19, and clinical trials of antifibrotic molecule should be considered to find a therapy for this menace. Thank you very much.
Thank you, Dr. Rajesh. We have around 15 minutes for discussion before I hand it over to the IMA for final comments. So one thing which I like to take you towards the pathogenesis of for the purpose of discussion. So the virus enters through the nose, so we can give zinc to nasociliary movement activation. So virus now enters the cell, so we can stop its replication by possible ivermectin. And then we have the transmembrane protease serine 2 inhibitors, which contains mefenamic acid, famotidine, and calonge, calmake, and we have serine 2 inhibitors. We have is, I'm forgetting one more drug. Now the virus enters inside the cell. You can stop its replication at RDRP protection by famotidine. Suppose you have not been able to, now it enters the cell, starts multiplying. You have blocked it by RDRP by giving either firoperavir or you have given remdesivir. Now still the virus enters the lungs. Okay. When virus enters the lungs, it will have to go into a it depends upon whether it is a hyperinflammatory innate response, which will be defective macrophage, neutrophil, or lymphocyte response. If it is a defective lymphocyte response, it will lead to TH, this is T helper cell response, will produce TNF alpha and IL-1. IL-1 beta is not produced here. So IL-1 beta doesn't come as a part of TH1 response. IL-1 beta, which you are talking about as the predominant, but I want to concentrate on IL-1 beta response. So IL-1 beta will come through macrophages. Through macrophages, it will go to NLRP, not like receptors protein 3 pathway. Through nuclear factor kappa beta pathway, it will produce IL-1B and IL-18. Now, IL-1B is linked to hyaline membrane formation. So therefore, happy hypoxia somewhere is linked to IL-1 beta. And that you also mentioned very clearly, IL-1. I have only said is IL-1 beta because IL-1 is further divided into many types. So if we can anticipate IL-1 beta early enough, so what can be the marker of IL-1 beta? So what I have seen is when there is a IL-6 fever or interferon fever, that particular movement, it is because of thermoregulatory dysregulation, and the fever is always less than 100. When you read about IL-1 beta, this is called as a pyrogen interleukin. So IL-1 beta is the pyrogen interleukin. In my observation, I'm very emphatic that fever more than 100 means pneumonia, patch, and fever more than 101, fever more than 101, aankh meech ke CT kara lo, pneumonia milega, and I call them as IL-1 beta fever. So my criteria is on day 3, day 4, or day 5. if you get IL-1 beta fever, you attack IL-1 beta there. And if you attack that, the secondary CRP rise may not occur. So when we look for IL-1 beta inhibitors, there are many plants, many households, and important one which comes from inflammasome is two things. One is colchicine and second is mefenamic acid. So colchicine is a classical IL-1 beta inhibitor. Colchicine now has been approved for treatment of chronic coronary artery disease. So all patients who are high risk with low-grade inflammation as an anti-inflammatory action, colchicine has been approved. And second is mefenamic acid, which is a king, which is inhibiting nuclear factor kappa beta, which is preventing formation of macrophage 1 to macrophage 2 reaction, which is reducing NLRP and which is also reducing IL-1 beta. So what I am giving in such cases is, whenever I find that they are having high-grade fever, if the fever is more than 101, I say this is IL-1 beta response. There with steroid, I add them mefenamic acid and colchicine, and I'm finding them not ending up into severity in such cases. This is my scientific explanation. So try it out in few cases and see that. So therefore, if you have any evidence, clinical evidence of IL-1 beta, add colchicine, mefenamic acid. Now this mefenamic acid, I will also use it as a steroid sparing after the steroids are withdrawn. So when I withdraw the steroid, and if I don't see second wave of CRP, so I continue mefenamic acid. Colchicine, I continue them for 3 to 6 months. And I'm also giving them this oral anticoagulation, which is dabigatran for 3 months. Any comments?
No, I think you have a reason to give it, but somehow I have no experience of using colchicine or mefenamic acid. Steroids, of course.
Colchicine, we have been using extensively in coronary artery disease. I've been using colchicine for years together for stable coronary artery disease for years together. It's safe. So because it is safe and we know it is IL-1 beta inhibitors, there is no reason it is going to contraindicate. Mefenamic acid, when I was with Dr. Malviya, so I am also trained in rheumatology. So in all cases of inflammatory spinal arthritis, we used to give them mefenamic acid in ankylosing spondylitis for 1 year, either naproxen or inflammatory for 1 year. Another thing is paracetamol increases IL-1 beta. So it is just the opposite. Maybe in such cases, we are giving paracetamol that may be responsible for IL-1 beta inflammation. So paracetamol and indomethacin both increases IL-1 beta. Naproxen and mefenamic acid reduces IL-1 beta. So I'm sharing you anecdotal experience of not one, at least 1,000 patients. I'm saying this is my finding, observational study. Try it out. I'm only putting it as then both of them are not contraindicated in COVID-19. Colchicine, in any way, we are giving in all patients of coronary artery disease. So my patient comes with coronary blockages with COVID, and if he's not on colchicine, so I'm in any way going to give it from CAD point of view. And colchicine is only one tablet, 0.5 milligram one daily, and it is a IL-1 beta inhibitor. Anyway, so besides that, we are also seeing lots of patients of pulmonary fibrosis. But anecdotally, we are seeing most of them are recovering. You also said around 80% recover. So what happens to those 20%? Can we identify some marker for those 20% who are not recovering?
No, the people who land up in the ICU and remain on respiratory support for a long time. What I have seen is people feel very happy that patient has not been intubated because they feel the family also doesn't want everything, but they don't want patient to be ventilated. And in that process, the treating physicians keeps on giving high oxygen concentration. We have been taught right from the MBBS that high concentration promotes lung fibrosis itself.
Absolutely.
So giving 80%, 90% of HFNAC and patient is showing 85%, 86%, passes that becomes negative, comes to the normal ICU, keeps on struggling for breath, eventually gets ventilated and die. Many of these patients, not one. So this is, these see, if we should ventilate them as we have been ventilating any ARDS patients. And you know, the other thing is these patients, because they keep on giving high oxygen at home or in a nursing home, so the patients comes to the hospital very late and they don't do well. We see quite a very severe kind of patients. And I feel that anybody who is above 70% of oxygen, 60 to 70% of oxygen, is not maintaining oxygenation, is in 80s, you should start thinking of intubating. And I have not one, many of the patients whom we have intubated early, we have extubated also early, and they don't get that much of lung fibrosis if you ventilate with that lung protective strategy.
So
You know, all over the world, people are ventilating now because they also went on to not ventilating and continuing non-invasive or HFNAC. But now they have changed their strategy because of all this.
That's a new learning and should be reported and should be discussed at various levels. Another thing which I'm doing is following them with C-reactive protein on the basis that CRP starts rising 4 hours after injury, double every 8 hours, peak at 48 hours, and crash in 17 hours. So many patients we are seeing that if the CRP doesn't crash, so one criteria we are taking is day 7. If the lymphocytes doesn't crash, means doesn't start rising on day 7, we say the virus load is very high. That's one criteria we are taking. The second criteria we are taking is a fall of more than 20% of lymphocytes in one day. That means viremia is very high and the patient requires something. Now, we have given to a couple of patients to thymosin alpha at that moment. Thymosin alpha is like Neupogen, which you give it in cancer. In cancer, you give Neupogen to increase polymass. Thymosin alpha 1.3 milligrams subcutaneous can be given to temporarily raise their lymphocytes. And this can be given like exactly like as you give Neupogen. And on day 7, if we find that their lymphocyte counts are reducing by 20%, or the absolute count is less than 1,000, we would give them this particular medicine. Number 2, we will go ahead with to reduce the inflammation. Instead of tocilizumab, we will talk about baricitinib. Baricitinib is a JAK1 inhibitor, which you also talk about JAK kinase, JSK kinase. You also mentioned in one of your slides. So baricitinib is a JAK1 stat. This is a JAK stat pathway inhibitor. Does not allow nucleus to give signals to produce multiple cytokines. So this is a multiple cytokine inhibitor. So on day 5, day 6, day 7, if we find the patient is having either a relapse of CRP or he is showing very high degree of inflammation, you have two options, either to uplift prednisolone at that particular moment from a low dose immunomodulator to immunosuppressant, or you add steroid with baricitinib, take steroid out. Baricitinib will take 3 days to act. By the time steroid have taken, then baricitinib takes over. And baricitinib does not cause tuberculosis because infliximab which is also a TNF alpha blocker, is linked to tuberculosis. There is the chances of infection with baricitinib are same as that with tocilizumab or with high dose of steroid. So that's another thing. Then I spoke to Dr. Rohit Agarwal, rheumatologist in USA, and I brought him in my show. And he clearly said baricitinib we are giving routinely in OPD patients to all our rheumatoid arthritis patients. So a drug which is safe enough for a OPD practice, oral 4 milligram. So he says most of my patients are on baricitinib in rheumatoid arthritis patients because their multiple cytokines are involved for inflammation. So that is another thing which can prevent the crisis. So I'm only talking about the day 4, day 5, day 6, day 7. So I basically want to debate on day 4, 5, 6, 7. If you do that, you may be able to prevent the second week crisis. So my whole objective of my IMA has assigned me a job to reduce the mortality. And my inference is if you want to reduce the mortality or a post-COVID complications, you have to work on day 5. So for me, day 5 is the most important. So I say by day 5, your CRP should crash. By day 7, your lymphocyte should start rising. By day 10, your CRP should be formula of 10. By day 10, if your CRP is not less than 10, you're missing something. So all my work for IMA and CMAAO in the last 1 year is concentrating on day 3, day 4, day 5, day 6, day 7. So if you work at that particular level, whether you are in an OPD practice or a clinical practice, you can reduce a lot of people going into severity.
You know, I have used in 2 patient baricitinib because after the paper of remdesivir and baricitinib found to be superior to remdesivir alone on 11th of December. Fortunately, those 2 patients have survived. They were pretty sick, but it is too early to say whether it has a role. But I have given along with the remdesivir. This drug has
See, the trial is that
allowed
US
by the
trial.
government of India, still not been allowed. But since the data is there, probably they will include for the COVID-19.
No, I'm saying is baricitinib was given with remdesivir because remdesivir is essential. They can't do a trial without remdesivir. And it was remdesivir plus baricitinib versus remdesivir. So the effect is coming of a baricitinib because remdesivir was given in a placebo also. So effect came of a baricitinib. Baricitinib, I've spoken to all the rheumatologists. All of them are using as an OPD practice. Couple of my patients are on. It is available in India. And if you buy it from the company, it's very cheap. It costs you only 6,000 rupees for a week's treatment.
No, 21,000.
No, that is in the market. That is in the market. If you buy it from the company, it's 6,000 rupees. So I have a couple of my patients have been given baricitinib, and so I prefer baricitinib over tocilizumab. But under cover with steroid.
Tocilizumab we have stopped for last 3 months.
And because of infection.
It is of no use, and baricitinib does not cause that much of secondary infection, and as the tocilizumab was.
See, baricitinib is it is a non-infectious. This is a monoclonal antibody which is not supposed to cause that much secondary.
This is by the baricitinib which is available by. It is Olumiant.
Yes, I know. So therefore, I'm saying is baricitinib is another one which can help on day 5, day 6, day 7. I'm only talking about early inflammation. So earliest inflammation packing I see is re-peak of CRP. Once your CRP have started declining, and if it starts re-peaking, attack there, then to let secondary pneumonia come. So if you attack at that particular time, so CRP is indirect marker of IL-6 and fibrinogen, because IL-6 will cause increase in CRP through the liver and production of fibrinogen. So if the CRP is crashing, and there are enough number of stories which says that CRP will crash much earlier than IL-6 and D-dimer. So therefore, I always take logo say CRP crash hua ki nahi hua. So if the CRP is crashed, I said you are now going to become all right. You are now going to regress with that. And then with this, I add colchicine and mefenamic acid as a routine, because I'm very clear that IL-1 beta, all this, the monoclonal antibodies, again, IL-1 beta are very costly. So many people can't afford. Why can't we find out a cheaper version of that? The cheaper version is Calmeg, Kalonji. Kalonji is what we use in achar. And Calmeg is Charayata, which is a common household kitchen herb. It is not Ayurvedic herb, it is a kitchen herb. So Kalonji and these two, which are, because achar khao, basically आपने यही बोलना है कि achar खाओ, उसमें kalonji अपने आप से आती है. Mefenamic acid and colchicine. IL-1 beta. And then we don't have at the moment, we don't have at the moment any antifibrotic apart from these 2 drugs. And there is no data to say one is superior than other. And there is no data to say how long to continue. But why can't we prevent going into fibrosis? Why can't fibrosis is inflammation? So attack on the inflammation. And it's another thing is inflammation begets inflammation. Second thing is inflammation begets thrombosis. Thrombosis begets inflammation. So we are giving them extensively oral anticoagulation at a therapeutic dose for a longer period of time. Because now they are talking about the role of microvascular angiopathy, which can cause thrombosis, microthrombotic episode, which can be at a very small level. There is a thrombosis. Continue anticoagulation for a longer period of time. So over to Dr. Ashokan.
Thank you, sir. We have the Vice President, Dr. Narasimha Reddy around. I would want him to make some comments. So please, sir.
Thank you, Ashokan, sir, and good evening, KK, sir. Sir, basically, I'm a radiologist, and I have a hospital where I do admit COVID patients, sir. And right now in the hospital, I've got about 7 patients with us. And the recent trend, what we have observed was the incidence in Telangana has come down. But of late, the last 10-15 days, again, we had a lot of people coming to the OPD, and late in the night, people are coming to the hospital with shortness of breath and dyspnea. And when we do a CT, we are seeing a Corat 5 picture, and we are admitting the cases late in the night. Now, as Chawla sir had just said that HNA-C is not that useful, but in fact, we have been putting patients on HNA-C. In the last 2 patients who have put, they have recovered very well. But this is really an eye-opener for us also that this is causing more damage than good to the patient. Sir, in fact, today
HFNAC is very good, but high FiO2. What I say that 80%, 90% don't go for that oxygen. HFNAC is a more we also use with 50, 60%.
So, but we are going up to 25 to 30 liters also, sir, and sometimes we have built up to 40 also. But now the challenge, as you said, sir, when to convince the patient and attenders to go for a regular ventilation. This is the challenge for us because people offer non-invasive ventilation, but the moment you have to intubate the patient and put him on a ventilator. So, at what level do you advise us to tell the patient, the attenders?
You know, when a patient, like in any ARDS patient, when he requires high oxygen, when he requires 70%, 80% oxygen to maintain his saturation between 88 to 92%, that is the time you should ventilate them. Because what will happen is you will keep on increasing the oxygen to maintain saturation. And in that process, by giving high oxygen, you are leading on to fibrosis in that patient. And which you will never know that this cause, because patient will survive, fibrosis occurs otherwise also, and nobody will realize. But what we are realizing now is that when we change our strategies, now less patients get onto that kind of severity.
2 anecdotal observations. One was, in any way, everybody knows about Italy. When there were no ventilators available, they started leaving people without ventilators and they started recovering. I mean, this was the first observation when they said that non-invasive can be helpful, but now it's a good observation. Many of them may not, they may still require ventilation. The second important observation is my brother-in-law. He is in New York. He is in charge of COVID hospital in New York hospital. And he said that their observation, they said during that period when New York, there was heavy rush of patients. He said, we have no beds. So what to do with the no beds? They started doing tracheostomy and sending them back. So they said they used to do tracheostomy and they put them on oxygen at home and they used to send them back. And he says, people started recovering. So what about the role of early tracheostomy? Because now lots of studies are coming ever since I've spoken to him a couple of months back. Now every week I see a study, the role of early tracheostomy in such cases. Suppose you, instead of doing a mechanical ventilation, we do them early tracheostomy and put them on a BiPAP or CPAP. Their oxygen requirement, they come down. Is there a role of early tracheostomy?
See, when you do a tracheostomy and give a BiPAP through tracheostomy, that is invasive ventilation. You're giving through a portable pressure. But the moment you secure the airways, that is invasive ventilation. So this is no longer a non-invasive.
Agreed. But then still,
that is rather even worse because that is uncontrolled ventilation. That is a situation where you have non-availability of the instruments or equipment. But when there is availability, you should go for that. And we are doing tracheostomy like regular about 10th day. We get them tracheostomized, and 3-4 days they come off the tracheostomy also, like any other patients. And somehow we've learned over the 8 months how to go about. So far, whatever the literature support is also there.
Good. So
Sir, I have one more query, sir. Sir, right now I have a patient who's 70-year-old with Corad 5, and both these lungs are extensively, you can see the ground glass GGOs, particularly predominantly the basal, both the lower lobes are totally opacified. And he is maintaining a saturation of around 90% on 15 liters of oxygen, sir. So what do you advise us to do this patient now?
what is the CRP level as a
That I got to check, sir, because this patient got admitted in the morning. So we're just contemplating of what to do if things don't improve.
Here there will be a role of people like me and Rajesh together.
Sir.
I will work more on the inflammation side and the thrombotic side on those markers, how to reduce the inflammation, how to reduce the thrombosis, and ventilation parts, people like Chawla takes over.
So, sir, now what's the role of vitamin C? A lot of people are talking about the role of vitamin C, like more than 4 grams a day to 10 grams a day. Patients are also recovering.
So there is a role of vitamin D. Now, lots of studies are coming that high dose vitamin D, even up to date, now talks about high dose vitamin D. So vitamin D, some people recommend 60,000 daily for 3 days, and as a high dose. Vitamin C, there is no upper limit. Vitamin C. I mean, these ICU people are giving it any amount of vitamin C high dose. And zinc high dose means 100 milligram a day. They do work at the level of signaling pathways of, so they do assist. There's no harm in giving them. There was a person who, Dr. Russell's Ritter, who is an expert on melatonin, who spoke to us a couple of days back. And he was very clear about role of melatonin also, because he says is all those diseases where there is a thermodysregulation of the hypothalamus, there will also be a thermodysregulation of pineal gland leading to melatonin pathway may also be controlled with that. And another thing he said, which I agreed with him, he says, in a pandemic-like situation, don't look for the evidences, create evidences. And evidences by created with one principle, anything which is not going to harm, may benefit, give it. So he says, don't look at that there is no evidence to give it. He says evidence is, who is going to create the evidence? Is a principle we follow in America is, anything where we find it is not going to harm, may benefit, we will give. That's our trial, that's our hypothesis. So if you want to try anything, say vitamin C, is it going to harm? No. May benefit? Yes, give it. High dose vitamin D, is it going to harm? No. Can it benefit? May, give it. So he says, whatever comes in your mind, which may give you, if it is not going to harm, give it. And that comes as Bhagavad Gita, Krishna's slogan. Krishna also said in Mahabharata, ऐसा झूठ जो किसी का नुकसान ना करे, किसी का फायदा कर दे, तो बोल दो.
Sorry, you may have to say that in English also for me.
So Krishna in Bhagavad Gita said, any lie which is not going to harm anybody but can save somebody's life, speak that lie.
So thank you, sir. Thank you, sir. This was a wonderful session. I think we gathered a lot of points today. I'm sure that Narasimha Reddy also continues to enjoy these sessions. You are invited tomorrow, CWC. Support our cause to continue this service for another 1 year. We'll be making this proposal. So kindly support the proposal and get it passed through the CWC. I sincerely thank Dr. Ramesh Chawla I did not know that you are a very senior IMA leader, even senior to me. Thank you for joining us as an academician and clinician and enlightening us. Thank you, KK sir. Thank you, Nursing Reddy.
Thank you, sir. Thank you, sir.
KK
Thank
sir
you,
may
Raj.
close the session.
Yes. That's all for today. And let me thank Rajesh to be here, a close friend and a academician par excellence to be here with us. Thank you, IMA. Thank you, Dr. Shukan and Narsinga, who is at the moment, in the absence of the president, is the president of the Indian Medical Association. Thank you, everybody. We'll be back next Saturday with another session. Namaskar.
Thank you very much, sir. Thank